Good afternoon, and welcome back to Health Leaders, the Winning Edge program, a series of webinars touching on the topics and strategies that you need to know most. My name is Chris Cheney. I am the CMO editor for Health Leaders and will serve as your moderator for this session. Today's webinar is titled The Winning Edge for Bolstering Clinical Technology. Thank you to you and our audience for participating. Before we get started, for those of you participating in the live program, I have a few housekeeping details. Note that an on-demand version of this program will be available on our YouTube channel on Friday and can be accessed through our website, healthleadersmedia.com. To ensure that you can see all the content for the event, please maximize your event window and be sure to adjust your computer volume settings and/or PC speakers for optimal sound quality. Next, you will find a resources list for today's webinar on the upper right of your screen. Here we have listed the webinar slide deck and some additional materials for you to download. At the bottom of your console are multiple widgets you can use. To submit a question, click on the Q&A widget. It may be open already and appear on the left side of your screen. You may submit questions at any time during the presentation. However, please note that it is likely that your questions will not be answered until the Q&A portion of the program. Finally, should you experience any technical difficulties during today's program and need assistance, please click on the Help widget, which has a question mark icon and covers common technical issues. At this time, it is my pleasure to introduce our featured panelists for today's discussion. Dr. Eric Lee, Medical Director, Clinical Informatics at Ultimed Health Services, and Lori Walker, Chief Medical Information Officer, Presbyterian Healthcare Services. Thank you both for joining us, and with that, let's get into our discussion. First, please tell us a little bit about yourself and organization, and Lori, why don't you go first?
Yeah, hi, thank you for having me today. I'm Lori Walker. I am a pediatric nurse practitioner by background, still practice clinically. I'm the Chief Medical Information Officer at Presbyterian Healthcare Services in Albuquerque, New Mexico. We are a statewide healthcare organization, so serving Albuquerque, Santa Fe, Rio Rancho, and surrounding regional sites as well. We have 9 hospitals, 3 ambulatory surgery centers, about 1,300 Presbyterian Medical Group providers, 60 plus specialties, and 41 clinics statewide. So thank you for having me today.
And Eric.
Thank you for having me today as well. So I'm Eric Lee, Medical Director of Clinical Informatics at Ultimed. I've been with Ultimed for just under 8 years, double board certified in internal medicine and clinical informatics, and I still see patients about a half day a week in various clinics throughout our organization. Ultimed Health Services is the nation's largest federally qualified health center. We serve roughly 400 to 500,000 lives in Southern California, as far north as the Hollywood sign and with Children's Hospital Los Angeles, who we have a joint partnership with, all the way down to Huntington Beach and across LA and Orange counties. We have 60 plus locations. We have several entities, including a for-profit MSO known as Altura MSO. We have a Medicaid insurance product operating under a restricted Knox-Keene license, of which we are at global risk for over 300,000 Medi-Cal lives, known as Ultimed Health Network. And we also have a nonprofit foundation of Ultimed as well. So we have 4 entities across as well.
Excellent. Let's get into our discussion. How can you standardize clinical pathways such as order sets in the EHR to follow guideline-directed medical therapy and optimize clinical outcomes for specific diseases such as congestive heart failure and chronic obstructive pulmonary disease? And Lori, why don't you start us off?
Yeah, I'd be happy to. So I think for us with our work around our clinical pathways and order sets and our approach to standardization around that, I think we started with very high impact conditions. Some of those like you mentioned, heart failure or COPD, that have more mature guidelines where we may be seeing more variations in the care that's being provided, where we can see more measurable outcomes and really where we can kind of integrate those more into our EHR workflows. And then I kind of think we basically took those guidelines and put them into kind of computable clinical logic in the sense of our order sets or smart sets, looking at the inclusion, exclusion criteria, decision trees, medication rules, all that kind of basic stuff. And then I think we built our evidence-based order sets and smart sets with appropriate defaults. We're also an integrated delivery system, so we have our own health plan. We work very closely with our health plan pharmacy partners, as well as our health plan population health team. And so some of those quality measures and evidence-based guidelines that we're trying to drive adoption of, we will build those into our order sets or smart sets and somewhat default some of those, trying to, again, pre-check the evidence-based orders, default doses, certain labs that we want to monitor closely. And I think also when you look at cost, we want to make sure that we're not automatically defaulting things that maybe aren't evidence-based, that don't add value, but maybe add cost. So again, also embedding clinical decision support. I think it reinforces adherence to the point of care that we're trying to get across. So I think just building the smart set, we found maybe wasn't enough for us. Again, across 9 hospitals, trying to get everybody to use maybe the same order set in heart failure or COPD. Just building the smart set wasn't enough. So really the way that we use clinical decision support within the EHR to suggest the order set at the appropriate time of care, whether that be on the admission or certain diagnoses and rounding that might trigger that. And then I would say, again, multidisciplinary governance, physician, advanced practice clinician, nursing, pharmacy, all that plays a big role in the content that goes into the order set. And then being able to measure adherence and closed loop feedback, working very closely with our physicians and APC SMEs that are helping us with those evidence-based guidelines and the adoption and usage of the order set, and then feedback if things need to be changed or updated. The other thing that we've done with this is kind of used some generative AI in the sense of at the point of care being able to personalize a little bit more based off of labs or diagnoses, problems, things that we're seeing within the patient's chart, to be able to serve up some of these order sets and pathways at the right time for the right patient.
And Eric?
Yeah. So there's no magic recipe or shortcuts to standardizing clinical pathways. What Lori described is a lot of painstaking hard work, right? Have to get into the weeds and really make sure you stay on top of it. And it requires a lot of diligence within informatics. And so, we at Ultimed, we don't have the inpatient side aspects, but we do have our own set of challenges on the ambulatory side that we've, I've relied on a couple of docs on my team that have been able to, Drs. Arroyo and Jung, who have been able to develop express lanes within Epic, which is our EHR system. And so we utilize express lanes for standardizing wild child visits, annual wellness visits, even annual preventative or young adult preventative visits, in which we do ask and screen for SDOH across all of these different express lane visits. Because of that, we're able to launch the right set of screeners for the nurse to complete and ask and screen the patient for as part of the rooming process. And then the provider gets all of that and all that information, in which they're able to then submit the right referrals or make the right connections, have the right conversations and the right interventions. So that has really made a significant improvement in making sure we're standardizing our care and improving our care and making sure it's uniform across all, both counties. So that's one example. I think in this day and age, building your own smart sets, which we have done a couple. We have like a diabetes smart set, but again, it's what I alluded to before. You may fall behind. We found that Freestyle Libre, for example, you have to update that once the Freestyle Libre 2 is no longer being used, and you have to update to the 2+ and the 3+ models. And we have to make additional improvements or adjustments based on formulary changes and the like. So not only do you have to do that or update that, but now it's really what can you do to utilize AI to pull in clinical pathways from vetted sources so that you don't have to do the maintenance yourself from an informatics perspective. Because it used to be the old-fashioned way is, okay, well, maybe once a year we'll look at this, or some huge landmark journal article came out, and now we have to figure out how we're going to update this and make sure we, go across leadership and make sure we're all in agreement and we're all going to adopt this. And who knows, that's another 6 to 12 months before you make the appropriate changes into the order sets or the smart sets. So what we need, what can you do to make sure you're staying ahead of it when up to date, or another trusted source, right, actually updates the clinical pathways in advance. And they are, because the nation's experts who are releasing these journal articles are maintaining those clinical repositories of information. How can we benefit in real time? And so that's the benefit of AI, of figuring out how you're going to be able to integrate that into your EHR, and so that it appears at the right time within a clinician's workflow and when they're working on the front lines. Got to make it seamless.
And how are you use? Be more specific about how you're using AI to update your order sets.
For me,
yes.
So
Eric.
what we're doing right now, we're in conversations with a company, and I'm going through my physician leadership colleagues in multiple demos, and I vetted this first with my informatics team. This is the power of conferences, where I had a great conversation at a conference late last year with a founder of a company. I felt like there was I thought there was some great vision here, and so I started going down this pathway of, okay, let me look at this demo, let me look at this with a couple of the docs on my team, see if this resonated with them. And then now we're going down this pathway of, I presented it to physician leadership. They seem to be on board with it. Now they want to see a demo, went through our clinical pharmacy team as well. They want to, so they have questions as well. So you have to, make sure you have the right meetings before you bring this to governance for approval. So right now we're focusing on, we like to look at one example, which is just hypertension. Blood pressure control is a very common health plan measure, like a HEDIS metric or a quality measure, right? That is scalable. Obviously, you want to impact and control blood pressure as best you can. If they are diabetic, if they have dyslipidemia, high blood pressure that's not controlled for a sustained period of time can result in other downstream consequences like chronic kidney disease and eventual renal failure, increase your risk for heart attack and stroke, as we all well know. So the goal of controlling blood pressure and delaying or preventing downstream catastrophic, events is really important, right? And so that's one condition we're focusing on, of how can I make sure that our providers have the right evidence-based clinical decision support of, hey, this blood pressure is not controlled. Let me flag this and suggest, based on the medication dose that this patient is taking, I've already answered some of the questions that I can through the integrations, but this is where you're stuck, and this is what you need to address. You may need to change the dose, right, and increase it. You may need to change the medication altogether to a combination medication, right? And this would be in line with evidence-based guidelines. So give our providers the confidence to be able to practice, and knowing that they're practicing the right way, in a way that we want, that is beneficial for the patient, right? And for our providers. So yeah, hope that helps.
Well, that's great. Let's move on to the next question. How can you use alerts and prompts in the EHR to reduce waste in healthcare, such as avoiding unnecessary lab testing, radiology testing, blood product usage, and medication use? And Eric, why don't you start us off?
Okay. So we've been, with our EHR, there's they call them OPAs, or it's like our practice alerts, and formerly known as BPAs, right? Best practice alerts. And so what we've shifted to is figuring out what problems are we going to solve first? So for example, one of the, and I'm going through an example of ordering lab tests. Our providers frequently we found would order testing for H. pylori antigen, for example, and they would not associate the right diagnosis with it or the covered diagnosis. And what we're finding then is that we are responsible for paying out of pocket, several $1,000s per site for this test because of a lack of coverage. So how do we educate the providers at the point of care right when they're about to order it that, hey, this is not a covered diagnosis. These are the covered diagnoses. Hopefully the patient has one of these, and you can then adjust accordingly so that we're not coming back to you after the fact to potentially with an audit to actually ask you to change it later on down the line, or have to counsel you. We want to counsel you and steer and guide you the right way before you click place order or sign order. So what we've been doing is figuring out the covered diagnoses, trying to pull the history of the patient. If the patient has history of peptic ulcer disease or history of H. pylori infection or at present H. pylori infection or functional dyspepsia, those are the diagnoses we're suggesting and asking the provider to select. So there's just one way in which we're utilizing that. I think outside of the scope of this question, we're actually trying to steer folks with specialty referrals. So we looked at like top 10 external specialties in which we're referring to. Orthopedic surgery was one of them. And so what we've built over time, right, we've had a medical director over our sports medicine program who with the sports medicine fellowship. We've actually been growing our sports medicine program. So now we have internal referrals to our sports medicine docs. And we're saying within the OPA, it looks like you're trying to refer a patient to orthopedic surgery, but did you know our internal sports medicine team can cover these conditions or questions you may have? And so we've been able to help bend the curve of our, despite growing membership, we were able to bend the curve and flatten out and then start decreasing the number of external orthopedic surgery referrals, increase the number of sports medicine referrals. And then the next step in that is, how can we use our sports medicine docs to answer very straightforward questions for which they don't need to see them in person? So we then instituted an e-consult program with one of the docs on my team, is working with the sports medicine director of, let's place e-consults, and these are the conditions for which they're covered. And you can get a response back within 1 to 2 business days, right? And so then you're able to appropriately manage who really needs to be seen in a sports medicine clinic. What can you answer through an e-consult? And then truly send those out that really need the orthopedic surgery care. You send those patients out for appropriate care.
Great, Lori.
Yeah, so I would say we're doing something very similar. We have a clinical decisions support governance committee. Probably back in, I'd say 2017, 2018, we did a huge alert reduction program, big project. I think we reduced our physician and APC facing alerts, even nursing, by like 52%. We just found that we had a lot of ignored noise, right? And so we did that, and then I would say now, since then, we're extremely meaningful with our alerts. We have this committee that kind of approves all alerts that go into the system. We have operational leadership that owns the alert. So our clinical informatics team or our IT teams do not own the alerts in the system. It really has to have an operational leader and partner who owns the alert. Again, what's the problem that we're trying to solve? We kind of have guidelines that they have to follow and that we follow when putting alerts into the system. So I think who is it? What's the problem that we're trying to solve, right? Is the alert even the right tool? Where in the workflow is it firing? Is it in the appropriate? Is it at signing of order? Is it upon order entry? Is it at closing of chart? I mean, we found so many alerts that were firing on open of chart that people would completely ignore. You didn't have enough information. And so we've kind of set these guidelines in place, and then we kind of created subgroups. So I would say, like when you're referring to lab, we have a lab value analysis team. And so we look at high cost labs. We work with our health plan to look at denials that they're seeing. We have a huge denial project going on in the sense of like a thyroid screen, right? Really, you should no longer just be starting with a flat out thyroid screen. If the TSH is normal, is the free T4 and T3 going to then get denied? And so that's some of the work that goes up through our lab value analysis team. And we look at ways that we can put alerts into the system that are very meaningful in the sense of unnecessary lab testing. And really, again, educating our physicians, APCs, and nurses around the why that they're seeing these alerts. Same thing with radiology, right? Some appropriate use criteria in the radiology space of, maybe you should be starting with a simple back x-ray versus going to advanced imaging. And so again, trying to use those radiology, evidence-based guidelines on appropriate testing, and then, ultimately quality and safety of care for the patients. We did a huge blood product usage campaign. It was a huge campaign throughout our whole organization on ordering, 2 units versus 1 and what's appropriate. We used alerts through that process. Same thing with medication, as well as having a lab value analysis team. We have a medication value analysis team. And so we're constantly working with our health plan to, based on patients' insurance, what's on formulary, what's not on formulary, what may trigger a prior authorization that may cause more downstream impact to the patient, have to have them jump through hoops in order to get the medication covered. So yeah, I would say that's the way that we've taken a very meaningful approach to the use of alerts and prompts in our EHR. We also have a big dashboard. We have a biannual review of all of our alerts in the system with those operational owners, and we can go into our dashboard and determine how often the alert's firing, how often its action's being taken, it's being ignored. If it's not solving the problem that we set out to solve, then let's reassess it and either optimize it, make it better, or turn it off. Sometimes alert's not always the answer.
And go into detail about, I like this meaningful approach to alerts. What would you say are the essential elements of that approach?
With like the guidelines that we created, I think it was very much, again, what's the problem that we're trying to solve? Is the alert the right technology? If it's not, what are other options for technology? What's the action that we want them to take? We do not want any FYI alerts. We want them to be actionable. So going back to our previous question, is it that we want them to cancel this order and use this smart set, or consider this order? Or so are they canceling one and placing another? What's the action that the alert is getting them to take? And then I think, again, where in the workflow, we want it to be very meaningful, because we know that can be very frustrating to our clinicians. So where in the workflow, the audience, is this just to a certain specialty? Is this to all physicians and APCs? Is this just to nurses? Who really needs to be the audience to take the most meaningful action on the alert? And then I think the ask of the owner of the alert is that, we will be sending you data to review how your alert is behaving, and is it solving the problem that you set out to solve? What's the ignore rate? Is there a subset of people that are ignoring it? Maybe it's firing for a specialty, and that would be inappropriate. And so we should set some criteria, some more strict criteria around that and rules around that.
Excellent. Next question. How can you, and I know, Dr. Lee, you mentioned you're going to skip this one because remote patient monitoring is not something you're using at Ultimed. So this is a question for Lori. How can you use remote patient monitoring to avoid hospital readmissions and improve patient outcomes?
Yeah, so I think the approach that we've taken, is probably more from a population health perspective. We're working very closely with our population health team, both on our delivery side and on our health plan side. we're trying to focus on those high risk patients and high readmission, risk for readmission patients. So I think when we looked at ours, we were looking at congestive heart failure, COPD, hypertension, diabetes, CKD, some of those post-discharge surgical patients, and then some oncology symptom recovery patients. I think really, as we've rolled this out, making sure that you have the right escalation pathways around the RPM alerts, right? The appropriate alert thresholds, your triage process around it, your response times, intervention protocols are important, right? If the patients, send in the data and the information, and then you don't have the right intervention, the right response time, the right alert thresholds, and even being able to prioritize some of those patients that are coming in kind of risk stratify, it can end up just adding a lot of additional work. Again, you always want to integrate your RPM into your EHR, right? You want that data to flow into the EHR so it can be actionable right within. We use Epic. I would say flowing into dashboards where you can trend and monitor in basket if there's actions that are coming into in basket for interventions or things like that. Care management, is it nurse navigators, maybe in your oncology space? Is it in your population health team? Do you have care managers that are monitoring this? And then again, being able to use any of those clinical pathways that you've developed. So I would also say predictive analytics for early intervention. I think that's the key to remote patient monitoring is the early intervention. That's why you're doing it. So you're really trying to move from a reactive to predictive for that risk. And then again, so for ours, we've taken a care management approach and kind of a centralized care management approach in certain areas, as well as our nurse navigators, kind of a centralized approach with our nurse navigators in certain areas, and then our transitional care teams of nurses in our primary care. So that's kind of the approach that we've taken. I would say too, clearly, can't leave out the patient. They're probably the most important piece of this workflow, right? So engaging and incorporating, your patient engagement and support, very easy to use, automated as much as possible for your patient. Mobile reminders, mobile nudges on whether it's their weight or blood pressure or, medication adherence tracking, all of that, keeping that very easy to use for the patient, multilingual. And then I would say risk stratifying. This is something that we have learned too, is not every patient needs the same monitoring frequency, right? And so risk stratifying those patients that truly are at the highest risk and may need more nudges, may need more touches, may need to be sending information in more quickly, and then their response time or turnaround time based on their condition and the symptoms that they're sending back in, all needs to be taken into consideration.
And I know you were going to take a pass on this, Eric, but anything you want to add or any questions for Lori?
So, the only thing I'll add is, we've done this in the past where we were looking at CHF, post-hospitalization, right? And I think the lessons learned, because we're not live with it anymore, the lessons learned of when you deploy this, you have to decide, how are you going to support the patients at home? How are you going to support multiple languages? Are the devices going to be disposable, or where in which you just gift it to the patient, or are you actually going to go about trying to retrieve it once they've graduated from the program, right? Well, do the inputs actually work? Is the right patient using it, or is a family member using the tablet or the blood pressure machine, right? And so you have to verify a lot of that, and then they may have gone off to vacation for 2 weeks or several months and come back and, oh, I forgot how to use it. So how are you going to support any number of those scenarios? And, you have to be where they are, right? So I think that's the challenge in it, but there's enormous potential, right? Just back to my prior example of blood pressure control, something as simple as a blood pressure cuff and just, hey, let's have a schedule a telephone visit, and it may be the nurse following up to say, what is your blood pressure today, right? Let's get that in so that we can make sure and make adjustments, or let me schedule you an appointment with our clinical pharmacist who can help titrate or adjust your blood pressure medication because it's not quite where it needs to be. So there's a lot of potential for it, right? And there's a lot of power in terms of how it can bend the curve.
Yeah, I totally agree with you. And I think that's going back to my statement earlier of like the patient clearly being the most important piece to this whole process, right? You can have grand visions of how this might work for you or how you want to roll it out. And ultimately this is that patient engagement and their behavioral engagement and all of that is really, really important. We've started this very small, and I would say also really trying to take somewhat of a centralized approach with this, depending on the areas that we're trying to monitor, like you mentioned with blood pressure or heart failure, so that we do have kind of a centralized team that the patients are able to engage with, more consistently.
Yeah,
Excellent.
it really is and then how do you build or versus buy the content to manage and guide the patient through it, right? There's a journey in which you want to help educate them. So there's so many factors to consider in this.
Great. Next question. How can you use risk assessment to flag patients at high risk for deterioration or readmission? And Eric, why don't you go first?
Well, so that's a really good thought exercise to start with, right? And there's a journey that we've had at Ultimate, and Lori, I don't know, I'd be interested to hear your journey at Presbyterian. But when we first started looking at this a few years ago, we wanted to lean into Epic and use their risk of admission or risk of ED visits. And looking at that, what we had issues with were how do you accurately count the number of external visits to an ER or being hospitalized? We were getting duplicative events occurring, which would then overestimate the patient's risk. It's better to overestimate than underestimate. But then it may not have caught visits to other hospitals that are not covered by Epic's Care Everywhere, right? Which speaks to a larger interoperability problem and data problem of getting the right data to act upon and make an informed decision. So we really wanted to use Epic's algorithm, but we were having accuracy issues. So then we started looking at other options out there, and we landed on Hopkins' ACG model and built this in. But again, this is, ACG model may suggest really high numbers of patients. And just at a high level overview, there's they divide your patients into 6 resource utilization bands. Resource utilization band 0 means they have nothing on your patient. Patient never accessed healthcare, didn't, fill them any medications. You have no idea. They're just a health plan member. And then 1 through 5, 5 being the highest risk, typically those that are on dialysis, those that have metastatic cancer, or, so those are like, you're not going to be able to bend the curve there because they already have advanced disease states that are terminal. And you're not going to be able to improve. You can focus on quality of life, but they're already going to be a really high cost resource at your organization. With resource utilization band 4, those are the rising risk. 3 and 4 are the rising, medium to moderate or high level, high risk, rising risk segment of the population that you really want to focus on. What we also referenced was, Dr. Robert Pearl wrote this paper on their journey at Kaiser Permanente over the past 20 years. And he defined, he espoused an approach of why Kaiser screens everyone in the general population. You screen everyone because you then want to keep people healthy for as long as possible, but you also want to identify cancer as early as possible and intervene because that helps save lives. It helps improve the quality of life for that patient, and it also helps decrease costs, right, for the health system and for the health plan. So when you apply that broadly of, yes, there's a quality focus, we need to screen everyone, but what he found was the highest, the top 5% of utilization and cost in terms of the patient population at Kaiser, you had to divide that 5% into thirds. 1/3 would have catastrophic events that you could never anticipate, like just a horrific car accident, right? And patients otherwise healthy, but they may be a top 5% cost patient for that year. The other third is, again, what I described, advanced terminal disease states like dialysis and advanced cancer. But the other 1/3 is who is going to be that rising risk population, and how do you correctly identify that? That is the goal of what you need to identify. So what we have looked at with ACG is, okay, we can do that. We can screen for, X number of ED visits within the last 6 to 12 months, X number of hospitalizations within the last 6 to 12 months. Are they, in the top 5% of cost to our organization? But you also have to account for the 80% of factors that are outside of healthcare. So social determinants of health or social drivers of health. And we focus on the top 3, Maslow's hierarchy of needs. Do I have a roof over my head? Where's my next meal coming from? And do I have enough money to pay for the things I need, right? So when you focus on those 3 needs and factor that in, that's how you're going to be able to come up with a better way of at least trying to identify who needs intervention, who needs deeper care.
Yeah.
Lori?
Yeah, I think this is an interesting question and kind of like Eric said, somewhat challenging. And I think we're in a space where we're trying a few different tools. So we have some of our own custom built out in the ED and inpatient upon admission and transfer and things like that we're trying to flag these patients. And like Eric mentioned, looking at those, trying to look at those clinical risk factors. Clearly, the social determinants of health are significant in that and plays into their risk. And then I would say, mental and behavioral health, plays into that as well. So, looking at all of that and having some of our own flags and risk assessment within ED and inpatient, and we were using some of Epic's predictive models in that space, as well as LACE scores. We're in the process of implementing Epic's population health module and using their transitions of care platform, which includes their predictive model for risk of readmission, which I think, Eric, you're right. If they're tapping your system, right, your EDs or urgent cares or clinics, where you can easily get that data, or other Epic healthcare organizations. But if they're hitting an ED or an urgent care that doesn't have that, then you're going to miss some of that data, correct? So, yeah, I mean, I think we're kind of in the same space, trying to figure out, what's going to be the right tool. We've taken kind of a centralized approach to our transitions of care and risk of readmission. When they do get discharged, we've recently redesigned our transitional care management team in that centralized approach. And just, based on that risk stratification and including all those things I just talked about, from their clinical factors, their social determinants of health, their mental and behavioral health factors, all of that playing into that score, then, what's our protocol that aligns how many touches that patient can get, right, or should get? It's not just a one and done in trying to, keep them from being readmitted. So this is a very complex one, for sure.
And when it comes to assessing, what's the right tool, what are you looking at there, Lori?
So again, I think it comes down to what's fully integrated into your EHR and what is working in the clinical workflows, right? If we're trying to get our clinicians, nurses, physicians, APCs to pay attention to this so that they know these patients are flagged as being high risk. And then again, upon discharge, right? That whole discharge care coordination that needs to take place. And I think trying to link, especially when a patient has been readmitted, like, hey, this patient was just readmitted 30 days ago, and this was their diagnosis on that initial, and this is their diagnosis now, and then understanding maybe what didn't go right when they were discharged the first time, right? How do we go back and kind of reassess that? How do we have kind of a closed loop on that specific patient? And is it something that our discharge care coordination team needs to focus on? Is it something that our physicians need to focus on? Is it DME related? Again, SDOH, instead of just kind of this revolving door, is really being able to reassess this whole closed loop process with these patients that are at higher risk. And then those that are a success that don't get readmitted, again, how do we evaluate that and understand what we did do successfully there, and are we missing that with other patients? So I don't know if it's any one tool specifically that's going to be able to, to fix this or to solve this problem, especially since it is really a true patient flow, and it's where patients come into the system, whether they're a direct admission, whether they're going through the ED, and if they've tapped multiple urgent cares before they got there, what did that look like, right? If sepsis was brewing, were they seen at the urgent care 3 or 4 times before that, and was there tests or anything that needed to be pulled in and really reevaluated? And is it getting to the right care team to be able to assess that and make the decisions? I don't know, Eric, I'd love to hear your thoughts on that.
I mean, so I completely agree with you. In my view, the risk assessment needs to happen so that it's on the back end. And then you figure out what do we need to do? It's not up to the frontline provider in the exam room to go through that saying, hey, I think you're high risk. Like, let me refer you to this program, right?
Yeah.
We need to take that, help them, because we're asking them to do 100 other things in the exam room. So how do we help them by saying, hey, this patient is being steered toward an enhanced care management program or a high risk program, or we just launched the street medicine program last month, right? So this is the perfect patient for our street medicine program, and this patient will follow up with you when able to get transportation, right? But figuring out what those flags are, and then how we intervene with that. But at the same time, right, it really comes down to, I know health systems are always watching their finances. It really comes back to, you still need social workers, you still need community health workers, you still need care coordinators. Like, to me, some of the most important roles out there, because they are doing that really hard work of chasing the patient down, meeting them where they're at, having the right conversations, and recruiting them to become, I would like you to enroll in this program. I feel like we can help you. And it comes back to trust, right? Trust is such an important thing in healthcare. So, the bottom line is, folks, I've heard about health systems that say, well, we don't really want to intervene and decrease readmissions. We want them to be admitted on post-hospital day 31, right? Just not within the first 30 days, so we can continue to feed our hospital systems. But, from what all the stuff that I read out there, there's so much ED boarding happening, really bad outcomes with having too many people inundating our nation's emergency departments. So really, what can you do to prevent or, redirect folks from going to the ED with avoidable, reasons for a visit, and so that we're freeing up our ERs for those that really need it?
Yeah. And I think you're right on. I think you're spot on in the sense of, where is it in the physicians and APCs and nurses that are providing that direct care? What information do they need? What's appropriate at the point of care to help them make the best decisions on these high risk patients? But then there's also this kind of whole back end approach, data and analytics and things that need to be dashboards and things that need to be monitored. And that's kind of a back end kind of closed looped process of being able to, review those patients, right? But then I think the care team is critical. And we're doing the same thing in the sense of, how do we best use our community health workers that we have embedded in our clinics, our embedded behavioralists and social workers, because so much of this does come down to social determinants of health and some mental and behavioral health complex problems that really do need a full care team approach.
So I'd like to, because we're running a little short on time, I'd like to skip to the last question that we had scheduled here, which is, how can you determine the ROI of technology used in clinical care? And Lori, why don't you start first?
Yeah, I think this has been the question of the year for 25 and into 26. Eric, you're probably feeling the same thing.
Absolutely.
Yeah, I think, I think, again, being very clear in defining the technology that you're using, its purpose. And again, I think we've all say this over and over again. I even have to say this to my team frequently and our clinicians is, what's the purpose? What's the problem that we're trying to solve? And is technology the right answer? And a lot of times it is. Certainly technology is driving a lot of the clinical decision support and evidence-based guidelines and the workflows. So again, what's the problem that we're trying to solve? Does this technology that we're looking at or want to use solve the problem? And then I think really kind of breaking it down to look at your total cost of ownership. I think we tend to just look at those direct costs of the technology and the vendors versus some of those indirect costs. And so really kind of looking at that total cost of the technology, measuring the financial benefits, measuring the clinical outcomes is probably one of the number one, right? Clinical value is probably the primary driver. And then I think, we rolled out ambient listening. We've also been rolling out a generative AI tool that's been sitting in our primary care space that has a summary built into it, has guidelines built into it, has clinical decision support. It's very hyper-personalized. It's able to look throughout the whole chart, back last 5 years, serve things up. It's great for chart search, chart review. It has an AI assistant, all of that, right? But again, so much of the hard ROI can be really hard to prove out. I think a lot of organizations have been struggling with the use of ambient listening and some of the other generative AI tools.
Eric?
Yeah, I look at ROI as because it's the question that plagues us in informatics. Yep. And how do you measure the ROI of an informaticist, right? And so, we're constantly asking ourselves this question in general, just to justify our existence, and tying it to the outcomes that couldn't have happened as well as they do, right? Because of the work we involve ourselves in. But ROI of technology, right? There's a hard ROI in the traditional CFO sense of, when am I going to get my return?
Yep.
And so you can look at that when you're moving from one vendor to another, for example, and there's a clear dollars and cents maintenance, license fee, implementation fee, et cetera, and you can calculate it that way. But what is ROI on quality? What is ROI on lives saved, right? And so this is why in healthcare, there's a lot of gray. It's not black and white like it is in the banking industry or financial industry, credit industry. Because there's a lot of gray, and because medicine is an art, right? It's healthcare. So there's a lot of gray in between, and trying to figure out that life saved, the quality improvement, the process improvement, that's more difficult to measure. But ultimately, and so, we implemented ambient listening as well a little over a year ago. And, to me, it's can you maximize the use out of it? So when we went live, we quickly hit our maximum thresholds within a couple months. We have over 75% of our providers still using it a year later. And 60%, about 2/3 of the folks are still using it for more than 70% of their visits. So the value is clearly there, right? Because it decreases cognitive burden, that they have this slightly improved sense of wellness. Are we saving them a lot of time? Maybe about 10 minutes a day, maybe 20, right? It's really not significant in terms of time savings is what we're finding. But do they feel like they can practice longer? do they feel like they can stay at Ultimate longer? And so it's a recruitment issue because this is table stakes for organizations nationwide. Folks, residents or new job applicants are going to be are already asking, do you have ambient AI? What's your vendor? Mm-hmm. And so if the answer is no to both of those questions, just like 10 years ago, it was like, are you on Epic? Oh, okay. I'm going to consider Epic orgs now. Ambient is the new sort of standard that you have to, it's the new table stakes. So there's that. So that's recruitment tool. It's going to be a retention tool. So we're in a partnership with California Healthcare Foundation and Mathematica. And we're looking at multiple ways of measuring the ROI, because the ROI that I've seen presented for ambient AI is really purely financial. Well, our providers are they're asked to see 1 or 2 more patients a week or a month, and that'll cover the cost of it. I actually have been resistant in caving in on that because I know how much is demanded of our frontline providers. Okay. So what I'm asking for is just, do you feel better using this? Do you feel like you could do this longer? Lori, you mentioned like summarization, right? Generative AI summarization, right? And we're about to go live with that in our Epic system too. Can you calculate an ROI on that? No. Can I measure the time savings in chart review and hopefully that'll add up over time? Yeah. And then can I feel like I'm serving, a purpose for our providers and helping them feel better about it? Yes. Right. But then there's certain, what's the ROI on wellness? Right. So there's so many different complicating factors about this question.
Yeah, I would agree, and when I go out and round with our physicians and APCs, especially with the use of ambient, they're just like, this has changed my life in medicine. Like I am truly, genuinely feeling the joy of medicine again. And so how do you measure that? Again, like you said, maybe some of these physicians were close to retirement and they're willing to work another 2 or 3 years because we've given them this tool. So it's not necessarily that we want them to see more patients. They also, I've had a lot of our physicians say, I'm actually able to have meaningful conversations with the patient again, where I'm truly involved in the conversation. I'm listening. I'm able to capture things because I'm not sitting at the computer trying to type things out. And so again, patient experience, provider experience, how do we capture some of that? Like you said, you're probably going to have the CFO tell you that a lot of that is soft ROI, but I think that's one of our purposes in clinical informatics, is to be the advocate for that soft ROI because it truly does matter.
It matters when you measure it in wellness surveys as well, right?
Yeah.
Like the Class Arch Collaborative, for example.
Yep.
That matters, right? And how you score and being able to come back to your organization and saying, look, like this is what our frontline clinicians, our licensed clinicians actually think of the product, of the EHR offering that we have and what we've done with it, right? So there's multiple layers to this that, a financial person strictly cannot figure out.
So let's move to the Q&A portion of the program. First, thank you both for an excellent discussion. We would now like to invite you in the audience to ask live questions of our panelists. As a reminder, if you are participating in the live program, to submit a question, click on the Q&A widget at the bottom of your screen. It may be open already and appear on the left side of your screen. Please note that your questions will remain anonymous and will not be viewed by other audience members. Now, as we're waiting for some questions to come in, because I don't see any in the box, I want to hold your guys' feet to the fire on hard ROI when it comes to clinical technology, because that seems to be the big question when it comes to clinical technology, which is you're making investments in it. But it's difficult to pin down any kind of financial ROI. Do each of you want to take another crack at that? And Eric, why don't you start us off?
Well, so, it's a conversation I have several times a week, because the reality is you have to manage within the constraints of a budget. So my diet partner is a CIO, right? And so we frequently have these conversations about, for example, we just had a conversation with our BFF at Epic of, does the AI pricing model make sense for us and our current consumption of AI with recent plan changes and pricing changes that Epic is rolling out? right? So now you have to redo your math calculations and figure out, does it make sense? Do we go into this all-you-can-eat buffet of a monthly standard buffet model pricing or suite pricing, or do we continue to pay a la carte or pay net metering, as they call it, and pay as we go? And what are the numbers, right? Based on what we have live, what we're planning to turn on live, what is that right switch point or transition point? So that's one example of trying to figure that part out. So you're judiciously and responsibly using the resources, right, budgeted for, within IT. And then there's conversations about like scanning, medical record scanning, there's current solutions of how do you store scanned data in Epic. And when you move from one platform to another, there's a pure just, dollars and cents. There's a cost savings in a project that we're currently embarking on, right, for later this year, to go live later this year. There's a true dollars and cents. And we calculate our ROI is within a year and a half, 1.5 years. There's another initiative for next year, potentially with our medical records department of, can we add on AI on top of that so that when I scan it in, I'm able to save time on manually looking at a document, trying to figure out where's the right place that it needs to go to. So I think that's figuring that part out and figuring out the efficiencies you gain, hours saved, I think is really important.
Lori?
Yeah, I think for us, as and I'll go back to some of the tools that we're currently using, I would say ambient listening. I think also really pushing on the vendors to help support finding that hard ROI. And if they have an organization or two that has truly solved for that, then I would say let's share that amongst all we're ultimately all trying to accomplish the same thing with adopting the tool in the first place, rolling it out, and then ultimately trying to find the hard ROI. And so I really think our vendors should play a key role in that as well, and really helping us come up with that. And so, if the vendor has one healthcare organization, and I'm bringing this up because I sat in a conference last year where it sounds like literally there was one, I think it was, 1 or 2, but maybe 2 or 3% of all healthcare organizations that were up on ambient listening had actually been able to solve the hard ROI. That's concerning to me, right? Because if you look at how many are actually up now, and the fact that we're all still trying to work on that, I think that's something our vendors really need to lean in and help us with and get us connected to those organizations that have solved for it and are seeing it and are doing it. And then let's all use that same hard ROI data that they're using, look into that and see how it fits for our organizations. I would even say too, one of the other ones that we're working on, and we have been an alpha partner with this vendor around the hard ROI, and some of it has, there's multiple, there's some HCC in it, there's suspected and non-suspected. So that goes back to what Eric had mentioned earlier in those non-suspected. Well, what is the clinical quality and how do you put a dollar amount around that? If I'm serving up, if the AI and the tool is serving up a worsening non-suspected condition, that if I take care of that right now at this visit, even if the patient wasn't coming in for that and I wasn't expecting to manage this today, but now my care has shifted because of this being surfaced up to me, and I start maybe with some lab work and some workup and medication or whatever needs to be done at that point. If I start that now versus if I saw the patient in another 6 months or 12 months and that condition was way worse, what's the quality and what's the dollar amount, and how do you contribute, how do you take that and put it back as a hard ROI with that tool? I would say the same thing, we talked about this a little bit earlier too, in referral orchestration. How do we get, access is a big issue in a lot, especially for our state with our specialists, but I think everywhere is seeing that. And so getting the right patient to the right specialist at the right time with the exact right workup to make it all meaningful. And if they shouldn't be going to that specialist at that time, then how do we use tools or AI within our EHR to help guide some of those primary care providers or maybe new APCs or residents fresh out on still managing that patient maybe in the primary care space? And what's the ROI to that? So very meaningful referrals, when they need to be seeing the specialist, and then maybe being able to not refer because they should still be managing that patient in the primary care space and they have more care that they need to provide.
Unfortunately, that's all the time we have for questions. Remember to follow along all week for continued coverage on strategies for bolstering clinical technology by visiting our website, healthleadersmedia.com. I want to thank Eric Lee and Lori Walker once again for an excellent discussion. And finally, thank you to you and our audience for participating. We hope you enjoyed today's program and look forward to seeing you during the future Winning Edge programs. This concludes today's program.